So let's say we're one of our listeners and they are now 45 and they want to be screened. How does that picture look? I mean, or screen preventive. So they've got no changes, but they think they should have their first colonoscopy. So literally pick up the phone and say they want a colonoscopy, or do they go to their GP? Or
So my personal feeling is you should probably be seen by a clinician before you are booked for a colonoscopy. And the reason for that is actually the worst part about a colonoscopy, and that's the prep. So you get given sodium picosulfate or a type of pico prep. And that means you flush the bowel out the day before in preparation for the actual colonoscopy. So the colon's empty. And that's a physiological insult. I mean, you take a bit of a knock there. Patients are slightly dehydrated. They tend to be a bit nauseous, and the electrolytes might be thrown out of whack, for lack of a better word. I want a clinician to say that's safe. So in our practice, I don't see all my patients that I book for a colonoscopy, but they have been seen by a GP in our area that we trust that says, this person needs a colonoscopy. I'm willing to prep them. Would you mind doing it? And then we'll see them on the day after the prep and actually do the scope. So the referral network is usually via your GP, unless you're already known to a surgeon somewhere who's willing to do it.
okay. Yeah, so and it'll be fine for us to then see them in our clinic and then refer on to you. Okay.
A question on the colonoscopy. So that's the gold standard because you can diagnose, you can prevent, you can treat all at the same time. So that's obviously the Rolls Royce. You want to do that. But there's other tests that we can do, and the question about the video capsule or a CT colonoscopy and things like that. I assume with the CT you won't pick up like early lesions, or would you still see them? Because you can't see them, you see it on a scan, so it's...
I'll be honest, the CT is a great tool, and it's, on the one hand, it's almost safer in that there's no perforation risk, much lower perforation risk. Having said that, a flat polyp, like the sessile serrated polyps, or sorry, terminology, but a flat polyp that doesn't stand up on the mucosa, you're not going to see, because a CT, it's amazing how they can reconstruct, and they almost give the radiologist a colonoscopy view, 3D reconstructed as they go through the colon. But it's looking for mucosal abnormalities. So on the one hand, they have false positives. So if something's stuck on the mucosal wall, it looks like a polyp, they're going to call it as a polyp, and you have to go for the normal colonoscopy to double check. And on the other hand, flat polyps, which are also some of the most dangerous polyps, are often missed. So you have a lower prevention and a higher false positive on a CT colonography.
Okay.
Other modalities, depending on the modality, will decide how accurate it is. CTs in general, my thumbs up is anything bigger than a centimeter you should see on a CT, but less than that, smaller or less likely. I'm trying to think of others, like a barium enemas and all the rest. They kind of follow the same mentality, but even lower sensitivity and specificity.